Good day. My name is Michelle Lavander. I'm the founding director of the USC Annenberg Center for Health Journalism. Thank you for joining us for our Health Matters webinar, How the Opioid Crisis Devastates Families. Drug overdoses killed more than 100,000 people in the US in 2021, and the highest death rates were among adults aged 25 to 54, prime years for childbearing and childrearing. And countless others couldn't care for their children as they confronted their own addiction struggles. The scale of loss and disruption for families is enormous. The mental health toll is incalculable. More than a third of children in foster care, according to the latest data, were removed from their homes because of a parent's overdose, death, or addiction. Nearly 3 million children, many of them orphaned by opioids, live with grandparents, caregivers who are grieving themselves and often struggling financially. Here to help us understand the toll, especially the mental health toll of the opioid crisis on children and families, as well as the services and resources they need, we have three distinguished panelists. Joanne Harrison Clow is raising her granddaughter following the overdose death of her daughter. She is a family law attorney in Pennsylvania and an advocate for policies that support families affected by the opioid crisis. Dr. Angelica Meinhofer is an assistant professor in the Department of Population Health Sciences at the Weill Cornell Medical College in New York. She uses big data to examine the impact of public health interventions and drug policies on substance use and health outcomes. And Dr. Laverne Mosley is a licensed psychologist in the Division of Child and Adolescent Psychiatry at Boston Medical Center and an assistant professor at Boston University School of Medicine. She's a specialist in trauma-focused therapies and the assessment and treatment of special populations, including children and adolescents in foster care. This webinar is made possible thanks to the generous support of the Christy Hammond Fund for Health Journalism and individual supporters like you. A word about our format today. We'll be hearing from our speakers first, and then we'll turn it over to our audience for your questions. Feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers in the Q&A panel. You can also write us if you're experiencing technical problems. We will be archiving this conversation later today at centerforhealthjournalism.org. Now let's get underway. Joanne, I'm hoping you can help us understand just the scope and scale of this crisis. And maybe we can start by asking you to briefly tell us what happened to your own daughter, Emily, and how you came to raise your granddaughter, Carter.
Well, I think it probably started, there was 4.5 years of horror before my daughter seemed to be safe in recovery and then had a bad afternoon where she relapsed and died. So my family story started in 2012. I knew there were drugs around. I had always talked to my children about drugs. I was a single parent. I had been married, gotten divorced, and my ex-husband had stopped seeing our children when they were 4 and 5 years old after he didn't win a custody case. He just decided to never see either of them again, even though he lives near them. So I was a 365-day a year parent. I had my own little family law practice, sole practitioner, and in 2012, I believe my oldest daughter, Emily, had some behavioral issues, and she had moved out of the house as a result of them. And then we started seeing each other and talking to each other. And then she called me desperate one day to tell me that she was addicted to heroin and she needed help. And I was so stunned. I'm not a naive person, but I did not see that coming at all. I knew she had done pot. I knew she'd done Molly, ecstasy. And then we started learning as best we could what to try to do with somebody that has that addiction. And she went in for detox. And then she went for, a 7-day detox. She wouldn't do a 30-day program. And it was just a yo-yo of hell for 4 years. She discovered in November of 2015, she was pregnant. She was 5 months pregnant, and she was doing 22 bags of heroin a day. And which was beyond horrifying. And she got an OBGYN. She made a decision to have the baby. She got an OBGYN who was very good dealing with addicts trying to have children. And she had to go on a methadone program because if she had gone through withdrawal, the baby would not survive the heroin withdrawal. So she did very well. She had the baby, and for 8.5 months, she seemed to be sober the whole time. I've subsequently learned she might have had one slip about 4 weeks before the day that she overdosed and died. She left for work on a Saturday afternoon. She didn't feel good. She had a head cold. She said she was going to go in early. She works at a sports bar as a food waitress and bartender. She said, maybe if I go in, Mom, they'll let me go home early. And then I got a call and the baby was living, she and my granddaughter lived with me at that point. I got a call. She never showed up for work. She was missing for 18.5 hours. No one could find her. When they closed the restaurant, everybody drove around looking for her. The police were looking for her, and they found her the next morning. Somebody saw her dead in her car at Starbucks, and she had never made it to work. And her autopsy showed that the only thing in her autopsy was caffeine, nicotine she smoked, and 100% pure fentanyl. No heroin in her system at all. The packet that she bought, 5 packets, and the packet she opened and used was enough to kill 40 people. And so she pretty much died instantly. And then I was, to say your life is turned upside down when you have a child die, it's just not even, you can't describe it if you've never been through it. But I not only had that, but then I had this baby, and the dad was an active addict. He was in recovery at the time, but not doing very well. He was living in a recovery house in Philadelphia by Kensington, which is a huge heroin area. And so I kept Carter. Emily had had a custody action with the dad where she had custody. And after a few weeks after Emily passed away, the father started kind of making noise like, oh, he was going to take some of the money people gave for a trust fund for her and take her and move to Louisiana and raise her down there. So I filed for emergency custody and got an emergency custody order. And we never dealt with the foster care system or the kinship program because there was a custody action. And that's what I knew as a family law attorney. I just filed to intervene in that and was given sole physical and sole legal custody. And for the first few months, it's horrifying going through this because you're trying to navigate legal systems and things when you can barely function because your child has just died. And Emily used to say before she died that having Carter saved her life, and it did get her sober, and she almost made it. One bad afternoon, she almost made it. Well, having me needing to take care of Carter kept me going too, because every few hours I had to get up and feed her and take care of her. But immediately, I never, even though I'm a family law attorney, I do custody, divorce, adoption, that kind of stuff. I don't represent a lot of people that use like the public welfare system or the subsidized daycare because they can't afford to pay private attorneys. So it doesn't come up a lot in my cases, but I knew there was a subsidy for daycare. And my first immediate problem was I was just turning 60 the month after Emily died. And I was winding down my legal career. Plus it had been in the toilet from taking care of Emily and the addiction things for 4 years. And the daycare was going to kill me because I had a daughter. My other daughter was a junior at American University, and I was trying as a single parent to pay her school tuition. And now all of a sudden I had $15,000 a year of daycare, just every Friday, $285, no matter what. And it was very hard for us. I did apply for the daycare subsidy program. And although my income was low enough actually to get it, they counted my other daughter's student aid work study money as part of our household income to exclude us from any daycare assistance, which still floors me. But I didn't have the wherewithal in me to fight that. So we went through that. I applied for Social Security benefits. My daughter, Emily, had always worked since she was 14. So when I went to get that, I found out the father had already applied for it, even though he only had supervised visits and was only seeing her 1 day a week. So I had to undo that. I went to go to WIC because Emily had WIC, where you get like milk and rice and cheese and only brown rice, not white rice, like very limited things. I went to get WIC. He had already started getting the WIC. And so here was an active heroin user, and I'm a family law attorney, and he was a step ahead of me on every single process. But I got it all straightened out and got that taken care of. I also made a decision pretty much the day my daughter died that I was not going to hate her father, that my granddaughter's father, I was going to love him because that is the only parent she had left. And if we didn't agree on stuff, we'd go to court and resolve it, but we were going to all get along. And we're 6+ years into it. Emily died December 3rd, 2016, and Carter just turned 7 yesterday. We had a bowling birthday party on Sunday. He came and his girlfriend came, and they have a younger child together. Carter has a little brother who's 19 months old. She has a stepbrother, and everybody worked together, and we had a great time. For the last 2 years, he's been sober enough to have unsupervised visits. So right now he has her on the weekends and I have her during the week. And it's been working. That's been working very well. But
Joanne, I just
I've
wanted
done a
to-
lot of sorry, go ahead.
I just wanted to mention a couple of things quickly. One is what happened to your daughter is really an outgrowth of this rise in synthetic opioids, and people think that they're taking something else. In your daughter's case, if I understand correctly, heroin, and in the end, something far more deadly. And as a consequence, you really faced a parent's worst nightmare, the death of your child, and then, this enormous responsibility that was made worse. You've shared with us by some of the hostile negative responses you received in the face of this devastating loss. People said things that would be unimaginable if your daughter had died of, say, cancer. So to talk a little bit about the stigma you experienced on top of this loss and this new responsibility, and what efforts and supports can help bereaved family members like you to cope and to have a safe and mental health, well-being for everybody in a situation like this.
Yeah, I started after the first few months, I started to do public advocacy. I got in touch with other people. People would just call me out of the blue. We were the first family in the area that put in the obituary that Emily died of after a brave battle fighting heroin, opioid addiction, and that she died, that she did not survive. She died from the disease. So a lot of strangers reached out to me because this was 2016. A lot of people weren't talking about it then. And she died December 3rd. And then my brother lives in Alaska, and one of his friends said, "Oh yeah, we read about your niece. She was one of the December people in the article of 52 people lost to opioids." So Emily's obituary was in there. So my name kind of got out there. So I started speaking out publicly. And in 2017, our local news in Harrisburg area, Penn Live and the Patriot News is the biggest news between Philadelphia and Pittsburgh. They made me and 2 other grandmothers who had lost their children to opioids and were raising their grandchildren co-newsmakers of the year for the state of Pennsylvania. So they had like a big above the fold newspaper article, and then online. And the first thing online, I told my other daughter, Diane, I can't believe the comments. And she said, "Oh my gosh, Mom, never read the comments." The very first comment was, "Why would you let that Joanne woman raise that baby when she couldn't raise her own daughter right?" And that was stuff, people would say things like that to your faces too. People asked me in line at my daughter's viewing, "Well, you're putting Carter up for adoption, aren't you? Well, you're not letting her dad have him. Well, I had own family members pull me aside and tell me I couldn't raise her." And so I came up with the term do-gooders. Is not a very nice term, because people that thought they were being helpful by just boldly suggesting things to you without you ever asking were not helpful. But you had that devastation of the loss and then the stigma of it on top of it. And I was determined that I am proud of Emily, and I am proud of the way she fought that right till the very end when she didn't make it and she died. And I think other people can learn from that. And she wanted to go and give speeches about it. She goes, "Mommy, when I get a little better with my sleep pattern with Carter, I want to go to high schools and you and I you talk about the parent and I'll talk about being the child, because what they taught me about drugs and what this was is not the same." And she had a terrible time once she was pregnant. We tried to get her in inpatient rehab and no one would take her because she was 21 weeks pregnant, high risk pregnancy. They would not take her. And they said, well, she could go into early labor or she could die. So she used to sit in my house. We would call 8 hours a day to rehabs and get turned down 2 phones, 2 of us, 8 hours a day for 2 weeks. And she would just stop, "Mommy, nobody thinks I'm worth helping. Nobody even thinks I'm worth helping."
Joanne, I want to commend you. I do think that newspaper had something right when they named you a hero. That's certainly true. We're going to come back to you. We're going to turn now to Dr. Mosley, who is working with a lot of patients and family members who've experienced something similar to yourself, to provide a bit of a bigger picture. Dr. Mosley, you've worked with youth and families for years. How has the opioid crisis changed this, the face of the families in crisis and the challenges your patients are experiencing? And can you tell us a little bit about that, and maybe hone in on one family or patient who embodies these new challenges?
Yes, hello, thank you, everyone. Thank you for having me. Um, Joanne, your story is pretty much very similar to a lot of the families that I've worked with over the years. I have a long history of work with kids in foster care, and while working in Philadelphia, actually, and then seeing the same kind of ripple effect here in the Boston area. And um, what I see, it's like this double generation, this multi-generational persistence of substance use over the years. I've seen a lot of children who are being raised by grandparents, or they're placed in some type of substitute care setting, either kinship care or foster care. But then, they may later find themselves falling into the same kinds of behaviors. And that could be due to the environment that they're living in, or just, it's like communities themselves have just been kind of decimated. There's so much of an influx of substances that are, being poured into communities. And so it's kind of hard for parents to even, or grandparents to stay ahead of what's coming down the pike, right? Because there's more and more lure that comes when we're dealing with substances. One of the struggles that I think that we're missing, are the after effects for those individuals who were substance exposed in utero, and the long-term effects that they're experiencing, whether they're developmental delays, which then lead to academic problems in school, or they may have fetal alcohol syndrome or other, medical issues. And oftentimes when we're thinking about this substance use, it's not really just one substance, right? We're dealing with a polysubstance issue. Oftentimes, we're hearing that some individuals may have started out with smoking marijuana and may have felt that it was, partly to help with relaxation, or because they were experiencing anxiety. And then, one thing leads to the next. And I know there's a lot of debate around, legalization of marijuana, and I'm not even going to get into, all of that. But I have seen, especially now with substances being laced, where, it's creating an even a larger problem, right? So we hear about the heroin piece, but we're also now receiving information about cocaine being laced, which oftentimes is used probably more in communities of color. And so we're hearing about cocaine, like huge deaths in Black communities, particularly in Boston, because they're finding that cocaine is now being laced with fentanyl. And there's a newer drug, I believe xylitol, which is even more potent than fentanyl, that is, popping up now in terms of the substance use. So there's just a cycle. I think of one family in particular that I was treating, the daughter who was being raised by a grandparent, and her father had lost his life to or had taken his life in suicide, or had a completed suicide. And the grandparent was raising her because her mom also struggled with addiction. And later in life, as she got older, she found herself going down the same path. And so we're seeing this persistence of this addiction and substance use, and lack of access to treatment, and just the struggles that families are experiencing on a very large scale. And it's hard to kind of keep ahead of it. Right. And so we have to think about, what are the things that we can put in place to help support families, because there's already that biological vulnerability to addiction that's present. And so we have to pay attention to that as well, and find ways to support families who are struggling, who are doing the best that they can to take care of their family.
And Dr. Mosley, just to clarify, in the story that you just told, the grandparent who was raising the child, that child then grew up and began to use drugs and struggle with
Yeah.
as well. So nationally, the rate of overdose deaths is increasing fastest among people of color, especially among Black adolescents. And we've heard from Joanne the barriers and the financial bureaucratic loopholes that she and her daughter faced. What are the particular barriers on top of that facing youth and families of color?
I think I'll go ahead, Michelle. I think that you may be having some technical difficulties. But in terms of communities of color, one of the struggles that we see is, stigma around seeking mental health treatment. Just being able to get out there and have access to services is something that is that's huge. There's been, especially for marginalized communities, we're seeing that oftentimes there's lack of access to resources or limited access to resources. We want to be able to break the stigma and that cycle of that there's nothing wrong with going to seek care for mental health services. But there are a lot of folks who struggle with being able to be open regarding their substance use histories, right? So that's a huge barrier for a lot of families. Folks are trying to figure these things out on their own. They're not they feel that they can handle it, right? Which is something that really creates a problem, or they feel that this is a private issue, or sometimes there are folks who may be using on a more what they feel is a recreational scale and not really recognize the scope of the issue. But I feel that within a lot of communities of color, there really hasn't been the access to the treatment that is needed. And so I know that there are a lot of communities currently who are trying to explore, what would make treatment more I don't want to use the word appealing, but what would make treatment more accessible to communities of color. And so I know that there are a lot of stakeholders now trying to explore that so that we can increase opportunities for whether it's outpatient treatment or inpatient treatment for communities of color. But it has been a long time struggle for these communities.
And Dr. Mosley, you've talked about intergenerational trauma and shared the story of this one family. Maybe tell us a little bit about what that means, how it manifests itself among your clients, and what interventions are being tried to break that cycle, and how can they be made more widely available?
Oftentimes I'll talk about like transgenerational persistence, and I said a little bit about it, recognizing that oftentimes there is there are biological vulnerabilities, and so addiction isn't just something that we see just in one generation, right? This is something that sometimes ends up repeating itself, right? And so it can be years of the same challenges that families are facing over and over again. And when we think about families of color in particular, we not just in terms of addiction, but when we think about generations of oppression or times of oppression, those things also kind of hinder access to care, access to treatment, continual persistence of negative experiences when it comes to, seeking care. And so we have to really be mindful of what are the things that place a lot of families at risk. And if individuals are not feeling that they truly have the that anyone is really going to pay attention to, what their needs are, or, they're going through, they're living in communities where their basic needs aren't even being met. It's going to be very difficult for, families to kind of overcome some of these barriers and struggles. And so, in terms of things that can be done, I mean, just as I had said previously, being able to provide more resources, provide more practitioners of color, folks who look like the individuals who are seeking treatment, is something that's really very important for individuals to be able to feel safe, to be able to, also be sensitive to, the impact of substance abuse in particular, and to be respectful of the struggle that a lot of families have been experiencing over time, right? We have to, be mindful that this isn't something that's easy, or that it's something that's a choice that they've made. But so we do have to be sensitive to the kind of language that we're using with the families that we're working with, and not to come at this with a place of in a place of judgment or blame for the struggles that they're feeling and experiencing right now. We have to look at, where's the funding going to be able to provide the necessary resources for families, being able to train and be culturally, have culturally competent clinicians providing care for families, providing the resources for foster families who, are also providing care for, for these kids who are struggling right now. So there's a multi-pronged approach that needs to happen. And, I'm sure that Dr. Meinhofer will also have a lot of thoughts around that, and suggestions around, what she's seeing as well, and looking at, the national numbers. But we have to first start with being able to be open and present, and letting folks know what resources are available and what's out there. I've done a lot of work with churches recently, dealing with, grief and loss around multiple areas. And I think being able to start at the places where folks are gathering, is also a place to be able to start, so folks know what is available and what's out there.
The one thing that we found helpful, there were no grandparent support groups or anything, when I started doing this. So there was a woman in the area who was a recovering addict, and she did a lot of public service work, and she started a grandparent support group. And that was very helpful. Now, everybody in my group wasn't people that just lost children to opioid crisis. I'm in other groups of parents that have lost children to the opioid crisis. And that has been very, very beneficial, having that group of people that just understand without even needing to discuss your own personal family story, just knowing people that have been through it. So having those type of I've helped also form a grandparent support group in our area and work with other areas doing that, because it's the grandparents that are suddenly, I know people in their 70s that have 5 kids under the age of 7 they've taken in because of opioids, and they've had to go back into the workforce, like 72, 74, just to be able to have an income to support the kids. So having those community benefits, we kind of had to build it because it wasn't there, but that was helpful to us here.
Yes. And, and I've seen some of those, grandparent groups, be very beneficial, right? Because sometimes it's, being able to provide that community, provide that, that support, because it is a hard road, right? So we're dealing with, a lot of grief, right? As you think of your own story, which I'm sure, so many folks, are able to resonate with. You're going through your own grief of losing your daughter, and then also having, on top of that, the strain of now having to raise, a young, vibrant young child, and yes, she may be keeping you young, but it requires a lot of energy to be able to, do what it is that, she needs and what she requires, and, but being able to have a community of folks there to, lean on, it doesn't necessarily make it a whole lot easier, but at least knowing that there are other folks who are experiencing this, other folks who are, also struggling, it does help to help you at least feel connected.
Yes. Should
Mhm.
I get started with my piece of the presentation?
That would be great, Dr. Meinhofer.
All right. Let me share my.
Sorry about that, folks. Our internet just crashed, so thank you for your patience.
All right. Can you hear me?
Yes.
All right. Excellent. So I want to start by thanking you for inviting me to be part of this excellent webinar. First, I want to start by using national US data to provide a general overview of both the magnitude and some of the consequences of America's opioid crises, both on children and families. And second, if there is time, I will review some of my policy research related to this topic. Let's see. I don't know why this is not easily moving. Okay, so the United States is in the midst of an opioid crisis. Needless to say, it began to develop in the early 2000s, and it's now become one of the largest and fastest growing drug problems in the country. Here in this figure, I am plotting the number of overdose deaths involving any opioids from 1999 all the way to 2021. As you can see, there was perhaps a slowdown in 2018 that came back up during the pandemic. The burden of the crises has heavily fallen on children, which are a vulnerable population increasingly exposed to opioids, both in utero or childhood through parental opioid use. And from the literature, we know that opioid exposure in utero may lead to a newborn experiencing adverse birth outcomes, which may include low gestational age, low birth weight, many others, while exposure to parental opioid use in childhood may lead to a child experiencing maltreatment, family separation due to parental drug overdose, mortality, parental institutionalization, such as incarceration or residential treatment, or a removal from the home and placement in foster care. Life course theory suggests that early life adversity, whether it is in utero or in early childhood, may lead to lifelong physical and mental health problems, substance use, and developmental, socioeconomic, and behavioral problems. So I want to start by quantifying some of what we know related to opioid exposure in utero in the United States. I will provide the caveat that capturing this information is very challenging and comes with a lot of data limitations, but here I will characterize or describe some of the more important studies that are out there, hoping to quantify this issue. So in the first graph, we have maternal opioid-related diagnoses per 1,000 delivery hospitalizations for the year between 2010 to 2017. And during this time, what we can see is that maternal opioid-related diagnoses increased quite rapidly by around 134%. The second graph captures admissions to substance use publicly funded substance use disorder treatment programs. And these are admissions related or due to an opioid use disorder as a person seeking OUD treatment. And it's stratified by referral source, whether it's coming from the criminal justice referral or other referral sources, such as the individual entering voluntarily or because of their friends and family, et cetera. And what we could see is that regardless of their referral source, there's been a dramatic increase in opioid use disorder treatment admissions, and not all of them involved medication for OUD treatment. Just to clarify, so these measures, both the hospitalization and the OUD, may capture any type of opioid use, whether it's prescription opioids or heroin or fentanyl. It's just an overall measure of high intensity opioid use resulting in an opioid use disorder. Here, instead of considering measures that reflect opioid use disorder, we're considering more generally patterns of controlled prescription drug prescribing. This is using claims data from the Medicaid population. And this is a sample, a very large sample of pregnant Medicaid beneficiaries. And the benefit of this data is that it's a little more recent. The previous slides, as I showed, the end time point is 2017, and there was a slowdown after that, in 2018 and 2019 and such. So this is a bit more recent, and what we can find is that there has been a decline in opioid prescribing, any opioid prescribing among pregnant Medicaid beneficiaries. Here we stratify for prescription opioids, prescription benzodiazepines, and prescription stimulants. And these declines, both in opioids and benzos, are consistent with overall nationwide patterns as the epidemic has shifted from an epidemic of opioid prescribing to one that is more fueled by heroin and fentanyl. Here, we are using self-reported opioid use data from the National Survey on Drug Use and Health, which is a nationally representative survey or sample. And here we considered measures of self-reported opioid use among pregnant females, both in the past year and the past month. We use a somewhat more recent data available for this survey. And what we can find is consistent with the overdose plot. There seems to be a slowdown in 2018. For both, we see it in the opioid use in the past year and in the past month as well. Here, we quantify measures of prenatal exposure to opioids that might affect infants. So in the first graph, we plot the rate of neonatal abstinence syndrome per 1,000 newborn hospitalizations. This is generated by the Agency of Healthcare Research and Quality, and it's using hospital data, and it has up to 2020 data, which is great because it allows us to detect the more recent trends and measures of prenatal exposure to opioids. And what we can see is that between 2009 and 2017, 2018, there was a dramatic spike in the rate of neonatal abstinence syndrome. However, since 2018, there's been a slowdown that seemed to have leveled off during the pandemic. Then the other graph plots the number of infants under 1 year and entering the U.S. foster care system. This between the years 2011 to 2017, and the top figure, the top line, quantifies overall foster care entries or the total, regardless of the cause or reason for home removal, whereas the second line quantifies those removals that involved parental substance use. And what we can see is that there's been an increase for both overall foster care removals among infants, and a lot of this increase, if a large share, if not all of this increase, is being driven by removals involving parental substance use. And they represent, I guess, about half of, they're involved in about half of removals for infants, although this is probably an underestimation because we don't always track well the reasons behind home removal in the data. It is of interest to consider how in utero exposure to opioids has affected or how the intensity of this issue affects populations or subgroups of interest across race, ethnicity, and socioeconomic status. Here, I grabbed the summary statistics table of a study by Hirai published in JAMA. And here what they plot is using the 2017 data is they stratify the demographic distribution for both the neonatal abstinence syndrome and for the maternal opioid related diagnoses. These are some of the figures that I showed you previously. It's sort of these same outcomes, and they also plot the share of those subgroups in the general population of births. That way, we're able to compare the share of that group in the opioid-related outcome and how that contrasts with the share of that group in the overall group, the overall population. And what we can see from these figures is that for both the rate of neonatal abstinence syndrome and for maternal opioid-related diagnoses, non-Hispanic white populations are dramatically overrepresented relative to their share in the general population. There is also a strong socioeconomic correlations where persons who are participants in the Medicaid program or in the lowest income quartile are also dramatically overrepresented in the population of persons who are experiencing neonatal abstinence syndrome or maternal opioid-related diagnoses. Lastly, being in non-metro areas, perhaps rural areas and less urban areas are also overrepresented in these outcomes. Then jumping into measures of parental opioid exposure in childhood, we grabbed a different study. Here, this study found that in 2017, the estimated number of children living with adults who misuse prescription opioids was over 3 million. Those who had a prescription opioid use disorder was over 550,000, and those living in a house where an adult used heroin was nearly 200,000. The figure here that can be observed tracks the number of households, both households with children and households without children. And over time, it plots the rate of prescription opiate use disorder over time. And as we can see, between 2002 and 2017, there has been an increase in the number of households where someone has a prescription opiate use disorder, both for households with children and childless households, although this would suggest a slowdown in more recent years for households with children. This other study plots foster care entries, and remember that now we're looking more generally at children, not just infants. Here we're focusing on the overall population of children that might be exposed to parental opioid use. And in the study, what we consider is also time trends between the year 2000 and 2017, and we looked into the number of foster care entries attributable to parental drug use. And what we find is that between this period, there was 147% increase in foster care entries that are attributable to parental drug use, even though entries for other removal reasons mostly declined during this time. And that you can see at the top is total entries. The orange line reflects total entries, whereas the line with the dots is the proportion of total entries that are attributable to parental drug use, and the bottom line is the number. So one is the proportion and the other one is the number, and we can see this very fast increase in foster care entries that are attributable to parental drug use. Here, in another study, they aim to quantify how this growth in entries, in foster care entries for parental drug use, varied across race and ethnicity. And so in the first figure, in the first plot, we have home removals involving parental drug use, particularly, and then in the second graph, we have home removals for other reasons that are not parental drug use. This way, we are better able to isolate the impact of, potentially the impact of the epidemic. There's, of course, other reasons that might explain these trends, but this study is hoping to do that. And then it divides the number of entries for a given race and group by the population for that given racial group and age group. And what we find is that from 2008 to 2017, the rate of parental drug use entries increased across all racial and ethnic groups. It increased across every single group. However, the level of and growth in parental drug use entries was greatest among Native American children. And I emphasize that both the level and the growth was highest for Native American children, which exacerbates existing disproportionalities in the foster care system for this population. Do we have time for more, or should I stop here?
Do you, I think we would love to hear these policy ideas. Do you think we could summarize them quickly in a minute or two and then open it up to folks' questions?
Yes. So a lot of my research has focused on the in utero piece of this puzzle, and one line of work in my research agenda includes trying to estimate the impact of prenatal substance use policies. So this is just to give you an overall of what these policies are. US states began to adopt a diverse set of punitive and supportive prenatal substance use policies in the 1980s during the crack cocaine epidemic. And since the opioid crises, the state implementation of these policies has spiked once again. To give you a sense of what these policies are, the supportive policies focus on providing access to substance use disorder treatment and related supports without discrimination, or ideally that would be the hope, whereas punitive policies punish pregnant females for their substance use. And unfortunately, these policies have become more punitive over time. To hone in and give you a sense of what exactly these policies are. So the punitive policies either criminalize prenatal substance use, define prenatal substance use as child maltreatment in child welfare statutes. It defines it as ground for termination of parental rights, that it can be used as evidence to substantiate reports of child maltreatment, and it may result in being placed in a child protective services registry. Whereas the supportive policies, there's two that my research has primarily focused on. One is priority treatment access policies, and then targeted SUD treatment program policies. So the priority treatment policies, for this policies, SUD treatment programs are required to provide pregnant females with priority access to substance use disorder treatment, which is particularly important if the program has a wait list or and one thing to know is that some of these policies may only apply to opioid treatment programs. Like it depends, the states vary in how the scope of these priority treatment policies. As for the targeted SUD treatment program policies, these are state policies that create or fund targeted substance use disorder treatment programs specifically for pregnant females. And the reason this might be helpful is because these programs are more likely to offer buprenorphine, methadone, which is medication for OUD, and other ancillary services such as child care, housing, employment, and social services. Some of the studies that I've worked on consider system responses such as child welfare system responses, maternal health measures, and infant health measures. In a snapshot, what we are finding is that the punitive approaches do not appear to improve perinatal well-being, and in some cases may be associated with unintended negative or adverse outcomes. We find potential increases in neonatal drug withdrawal syndrome, increases in infant and children reports, and decreases in prenatal care utilization. Whereas for the supportive policies, these appear to be a much more effective approach for improving newborn health and maternal health, of course, more generally, as we see, we're documenting some declines in low birth weight, low gestational age, increases in prenatal care, increases in buprenorphine treatment for OUD, and in some of the specifications, decreases in opioid overdoses. And I'll end here.
Thank you, Dr. Meinhofer. Folks, I just want to remind you that you can put your questions in the Q&A panel by clicking on that at the bottom of your screen. And while we wait for some additional questions, I wanted to just ask one of all three of you, which is, what storylines and reporting would each of you like to see on the impact of the overdose crisis on children and families, what's going untold, and what avenues might reporters pursue to bring accountability about these policies and benefits and the kinds of struggles Joanne talked about, and perhaps shine a light on some of the unmet needs in their communities?
The one thing that Emily and I experienced when she found out she was 5.5 months pregnant, was using 22 bags of heroin a day. That day, her boyfriend decided to go into rehab, Carter's dad, the same day. Rehab sent a car an 1.5-hour drive to pick him up and take him, and took him. Emily, 21 weeks pregnant, actively using heroin, needed medically assisted treatment immediately, couldn't get in anywhere. And we also learned that there is a there are way more beds available in rehabs for men than women. And Emily used to go, but I'm the one with the baby in me, mommy. Like, why can't I be the one to get the help? That was one thing she really, really wanted to work on. If she could do anything to make it easier for the next pregnant mom that was trying to get off drugs or do it the right way, was a huge concern of hers, just because of what we went through. And at the very end, her due date was early April, which I think they were off on. Carter was born on February 27th at the end of her baby shower. Emily's placenta abrupted and she almost bled to death at our house. They had to rush her by ambulance to the hospital, and Carter was born. She did not go through neonatal abstinence syndrome. We were very fortunate with that. But it was very, we could see the prejudice to moms, and we also were at the hospital with other moms who were active addicts who were not going to keep their children, and we were all in the NICU at the same time. So we saw all of that, but it was, that stigma was there too. We were told as long as she only tested positive for the amount of methadone she was prescribed, children and youth would not be called. And a do-gooder social worker decided to call Child Protective Services anyhow. So then we were terrified that they were going to take Carter, and they didn't. The very last minute in December, she got offered a bed in New Jersey at a place where she could stay. But in New Jersey, DIFAS, if you test positive, Carter would have been taken from her at the time of birth. And if she stayed in New Jersey and she had another child, even if she wasn't actively using, then they would take that child too. So that punitive part of it is a huge problem for moms, pregnant moms, when they're trying to get help. We were lucky we had a great OBGYN, but the hospital staff, even though we thought we had it all worked out, nobody was calling Child Protective Services. They did. We were lucky because they let the baby stay at my house because of me and because Emily had been compliant with the methadone program, but we could have lost Carter that day.
And I want to make sure that thank you for sharing this. Your accounts are just so invaluable. I just want to make sure we hear from Dr. Mosley and Dr. Meinhofer on what do you think is going, just sort of unnoticed about this. I think we've seen a lot of fabulous coverage about just the rise in synthetic opioids and the overdose crisis, but when it comes to families and children, this seems to be a less covered topic, and we would really welcome your ideas for the journalists in this audience.
I do think that, we have to pay attention to just like the long-term effects, right? So when we were thinking about like these adverse experiences that children face, and how that can manifest even in adulthood, right? So if we look at the longitudinal effect of growing up with a parent with substance use disorder, or a family where there's been a lot of disruption because there may have been incarceration of a parent, due to substance use disorder. We want to think about how, those adverse experiences can then lead to, physical as well as, medical issues, even in adulthood, right? We want to reduce the amount of long-term effects that can present themselves as a result of multiple adverse effects, right, that they experience in childhood. And when we think about those, it's like this, just the disrupted placement when kids are, being moved from home to home. If they don't have a kinship family that can take care of them, we see a lot of issues around abandonment, children with fears of rejection. There are a lot of trust and attachment issues, extended grief and loss, post-traumatic stress disorder, the learning issues, ADHD. And so we're seeing just a, population of kids who are growing up with so many adverse experiences attached to them that now affect or impact how they are going to, whether they're able to thrive or even have the skills to thrive in adulthood, and to even go on to be self-sufficient, right? And so in addition, we're seeing the mental health effects, right? Increased symptoms of anxiety and oppositional behavior, their own substance abuse. And so that's also a huge concern that also needs to be addressed and looked at. And another piece is the families that are actually taking care of these kids. They actually are, they can have the biggest impact on how well a child is able to recover from these traumatic experiences that they're having as a result of being separated from their parents. So I think that there are a lot of areas that can be, explored around, the impact, so not just looking at the folks, shooting up, but what's happening to the kids, who are kind of like left behind as a result of this. When we think about, kids who are aging out of foster care and may not have even had the resources to be with a family member, and they're just kind of left out there once they age out of the system. What are the outcomes, for those individuals? We have to pay attention to that as well.
Thank you so much for that really eloquent picture of just the long shadow of this crisis. I want to quickly turn to Professor Meinhofer, and then we'll take a question from one of our audience members. Did you want to weigh in on this missing storylines, what you'd like to see?
Yeah, so I absolutely echo the words of Dr. Mosley. We have a new generation of children exposed to parental opioid use, growing for over the last decade, and many of these children are being raised in unstable home environments. And who is going to advocate for these children? Who is, if the parents in some situations can't advocate for them, who will? And sometimes it is schools who can take some of that help, and making sure schools have the resources to support these children. Sometimes is other family members. I mean, it's a combination of and are there sufficient support services for other family members or these families more generally? Yeah, I think the main line is who will support these children, and how do we make sure that that we shed light on this new generation of kids who don't necessarily have someone advocating for them.
Thank you. I'm going to turn now to a question from Mackenzie Chrisman. I just want to mention quickly that our prior webinar to this one was looking at the rise of synthetic opioids, and we're going to put that in the chat too, in case any of you want to refer back to that. And we'll be putting this webinar on centerforhealthjournalism.org and Dr. Meinhofer's PowerPoint. So Mackenzie Crispin says, how do you see the opioid crisis shaping research and reporting as new drugs emerge in the market? For example, and I'm going to mangle the pronunciation of this, xylazine being difficult to trace since animal tranquilizers, aren't a scheduled class drug.
I think I would say that would definitely represent a challenge to research, because if we don't have measures to track substance use, then we cannot easily research them, at least not at the population level. So yes, I mean, oftentimes, however, data sets become updated to capture the new substances that are out there, but perhaps there is a lag in when we can start learning about certain patterns at the national level because of this same reason that you are noting.
And I'm just going to mention and ask, particularly for Dr. Mosley, do you have any suggestions for journalists who are interviewing either the, grandparent caregivers, other caregivers, or youth with sensitivity as they approach these stories?
Yeah, I would say, sensitivity, I think, is the key word, right? Being aware that there's already, shame and stigma that folks are experiencing as a result of having to share their stories. And, it's like their trauma is on display, right? And so, being, gentle in the questioning, and also as journalists are approaching some of these stories, just being able to be mindful of their own biases around, their own feeling related to substance use. And all those things that, all those unspoken things that we may not actually say about how folks may feel related to this crisis. So being aware of your own bias, being culturally sensitive, recognizing the use of newer softer language, talking about addiction care treatment, that we're not using harsh terms in relation to how we're identifying individuals who are struggling with substance use disorder. So trying not to use stigmatizing language in the approach, and just using gentleness and grace as folks are sharing their stories with you.
Yeah, no, thank you. And I don't know, Joanne, if you had any thoughts on that too. Just quickly, we're a little bit over, but just wanted to see from your grandparent perspective if you had some quick thoughts on that question.
For journalists, I'll have to say, honestly, I was very fortunate. The journalists were some of the kindest people that I talked to. And I had a lot of interaction with them. I mean, the local news followed Carter and me for like 3 days to a birthday party at Monkey Joe's, to watch me take her to daycare and back, come and see her, observe in the house. So I think they were pretty good with it. And they were not as, and I had to learn to use different terms. I had never used substance use disorder before. I knew, watching my daughter laying on a floor, sobbing hysterically, withdrawing from drugs that she was desperately trying not to use anymore, that she wasn't just a junkie and all the awful names people call kids and people. But we had a lot of problems with the medical community, to be honest. And they say, like, the average addiction training most doctors get is like 4 hours, and all the years of medical school it used to be. It's not, hopefully not anymore. But Emily was in a car accident, and she told him she was allergic to opioids and couldn't take the pain. Oh no, just take it as prescribed on the bottle. And Emily's like, well, it doesn't work that way. I can't take this at all. And the same thing, I was working with a community health center for a lot of disadvantaged families. I was going to be on a panel to deal with opioid stuff. And the nurse practitioner just turned to me and goes, oh, wait till your granddaughter hits 4 or 5, 6 years old. She's going to be on Ritalin. She's going to be on this. She's going to be uncontrollable. She's not going to be able, these kids are so screwed up from opioids. She went on. And I told her several times, that's not what my pediatrician is telling me. That's not the information I've been giving. And you know what? How about just lie to me at this point, if that's what you really believe? What was the possible benefit? I got up and left there, and the other people that were on the committee knew how upset I was. I pulled over on the way home, sobbed hysterically, and threw up all over the side of the road, because this woman would not let it go. And she was a medical professional. So I think that journalists have been very helpful. I've been lucky in our case, but because, and a lot of the community knows about us from how much we've been in the news. But I think medical professionals needed a little more help on You know, and one time we were in the room and Emily said, I'm allergic to opioids, closed the door, and she heard the girl in the hall, the nurse's aide go, oh, I went to high school with her. She's a heroin addict. She's a heroin. And I went to open the door to say something, and Emily took my arm and said, Mom, I'll handle it when we leave. And we
Mhm.
left, and she called back into the manager and handled it. But it's bad. It's bad. And in a community where you would think it wouldn't be,
Mhm.
in the medical community is not always very receptive to it.
Well, I want to thank our three really thoughtful panelists, Dr. Mosley, Angelica Meinhofer, and especially Joanne for sharing your really deeply personal story. I want to thank our audience. A number of folks have posted some very thoughtful remarks about just how hard it is to try and how we figure out how to end all this. We're going to be archiving this webinar later today at centerforhealthjournalism.org, and we'll be sharing a survey with you about this one. So we encourage you to weigh in. And should you like to support the work that we're doing to provide this kind of resource, please go ahead and contribute. This is how you can do so. And I just want to thank everybody and wish you all a wonderful day.
Thank you.